Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine, and this is the second of the three lecture series on Finerenone, a novel and game-changing non-steroidal mineralocorticoid receptor antagonist. And in this particular section, we will discuss the clinical research data and recommendation by various international bodies. First, the clinical research data. Now, there is actually very extensive data about this drug, and it is not possible for me to go into the details, but I'll give you the summary of three major studies. And the importance of this is that it actually led to its approval for a specific indication. Now, these are the three main studies. Figaro DKD. Figaro DKD is primarily for the study of cardiovascular events in type 2 diabetic patients with background kidney disease. And then Fidelio DKD, and this is primarily to study the renal outcome. Of course, the secondary endpoints also included cardiovascular. And then Fine Hearts, which just recently completed and actually published in New England Journal of Medicine in October last month. And this showed its benefits in heart failure with preserved ejection fraction. Now let me expose these and show you these points like number and follow-up, primary outcomes, results, and conclusion. This would be actually a summary. If you're interested, all these articles are available on New England Journal of Medicine. Now this Figaro DKD, the total number of patients was 7,437 and the average follow-up was 3.4 years. And it studied 4-point MACE, and you all know what 4-point MACE are. It is actually a composite of non-fatal myocardial infarction, non-fatal stroke, heart failure, or death attributed to cardiac condition. So a composite of these 4 points, and then the study showed the results are that Finerenone versus placebo, all these patients were on fully tolerated doses of RAS blockers. So the Finerenone patients, they had fewer events than those who were on placebo, indicating that Finerenone has got protective effect on cardiovascular event. So the conclusion we can draw is in type 2 diabetes mellitus and CKD grade 2 to 4, Finerenone reduces MACE points. So at the moment it is not actually approved for this indication, but it is very likely that Finerenone would be approved for this indication also in future. Now this is Fidelio DKD, and this was even bigger study, 5,000. So this was 5,674 patients, and average follow-up was 2.6 years. They studied 3-point renal endpoints, and this was actually death from the renal cause, kidney failure, or 40% reduction in GFR. In this case, the Finerenone people, those who were on Finerenone, in them the decline in renal function or death due to renal cause or kidney failure was much less as compared to those who were on placebo. Again, these patients were on fully tolerated doses of RAS blockers. And this concluded that Finerenone improved cardiorenal outcomes, renal as well as cardiac, when added to RAS blockers. Now this study, the last one, which was published on 22nd of October, New England Journal of Medicine, in this patient, 6,000 patients with New York Heart Association class 2 to 4 heart failure with preserved ejection fraction. Now the ejection fraction was more than 40. They can be called preserved or mid-range. So these patients were studied, and in them they studied the incidence of cardiovascular death, heart failure, and particularly heart failure hospitalization. And in the results were Finerenone versus placebo, 16% risk reduction in CVD or major heart failure events in those patients who were on Finerenone versus placebo. So again, Finerenone is a treatment option for people with heart failure with mid-range ejection fraction like 40 to 60. So I think these are the three major studies, and if you're interested, they're all available in the New England Journal of Medicine. Now, based on these three major studies, Finerenone is approved by FDA, EMA, Health Canada, nsMRA UK, TGA Australia, PMDA Japan, NMPA China, and DRAP Pakistan. Now, this is particularly approved for this condition in adults patients with chronic kidney disease associated with type 2 diabetes. Now, we cannot extrapolate for other indications. Of course, off-label use is possible, but currently this drug is used for those who have background kidney disease and have type 2 diabetes, because it's shown that Finerenone is indicated to reduce the risk of sustained eGFR decline and end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. So if Finerenone is used in this situation, we can expect a reduction in all these events. Now, I have already told you that it is indicated on the top of standard of care treatment, which is renin-angiotensin-aldosterone blocker. So now let me present the other component of this part, which is recommendation by different international bodies. Now, first of all, American Heart Association Presidential Advisory. Now, this is very busy slide. You won't be able to read it from here, but I have given you the summary. This is the summary. First of all, of course, they emphasize that implement life's 8 essential, which is actually primordial prevention. That means you must maintain your general health like weight and regular exercise, sensible eating, avoidance of smoking, not too much alcohol. So all these 8 essential must be done. Blood pressure control, diabetes control. So after this, you must also in stage 1 manage weight. That in stage 1 actually there are no other manifestations. You just have visceral obesity. So I think they emphasize that you must manage weight primarily by reducing food intake, but also by doing regular exercise. In stage 2, when you have some associated laboratory abnormalities or some metabolic abnormalities, then you must treat those conditions. Like if there is coexisting hypertension, that must be treated preferably with RAS blockers. And if there is hypertriglyceridemia more than 135, that should be treated with lifestyle changes or with gemfibrozil or fenofibrate. And if there is hyperlipidemia, you may be used treated with statins. And also on the top of that, I think if they have background kidney disease, they may be offered non-steroidal mineralocorticoid receptor antagonist, which is Finerenone. And in the third stage, when they actually have subclinical cardiovascular disease, then it is recommended to add some antiplatelets and statin treatment, even if they have normal lipids. Now, what does NICE say? NICE is National Institute of Health and Cardiac Care Excellence. It's a British association, and it says the recommendation about Finerenone. Finerenone is recommended as an option for treating stage 3 and 4 chronic kidney disease with albuminuria associated with type 2 diabetes in adults. And it is recommended only if, this is the disclaimer, it is an add-on optimized standard care. So these patients must be getting adequate treatment for their glycemic control. Their glycemia must be controlled and should include, unless they are unsuitable, the highest tolerated and licensed dose of angiotensin converting enzyme inhibitors or angiotensin receptor blocker. Never both. So either of the two they must be taken. On the top of that, you can add Finerenone. And they must also be getting, because in diabetes, sodium glucose cotransporter SGLT2 inhibitors, they have also shown a very promising effect, and this is primarily glucose lowering therapy. So in the primary control, they must be getting SGLT2. Of course, there are some contraindication. If they're not taking a RAS blocker or SGLT2 inhibitors for some contraindication, they can be put on Finerenone without them. Otherwise, first these two agents and then Finerenone to be added. and the person has an estimated GFR of more than 25. If that is less than 25, then Finerenone is contraindicated because it can cause some kidney damage. So this is nice guidelines. Third one is American Diabetes Association and Chronic Kidney Disease and Risk Management Standard of Care in Diabetes 2024. They have also identified that those patients who have background kidney disease and type 2 diabetes, they can be added on this non-steroidal MRAs. The KDIGO, this is Kidney Organization, they in 2022 they issued practice guidelines, and they have also recommended that of course the first line treatment, the lifestyle changes and the proven therapies, metformin, SGLT2, RAS blockers, statin, and then the third stage they recommend this is non-steroidal mineralocorticoid receptor antagonist. And in the first lecture, actually in the first part of this lecture, I hope you have watched that video. I actually emphasized how these non-steroidal MRAs are different than conventional steroidal MRAs. So I think in this particular indication, non-steroidal MRAs are recommended because they have shown distinct benefits because of their unique ability of anti-fibrosis and anti-inflammatory properties. Then European Society of Cardiology, they have also included MRAs in their recommendation. This basically refers to non-steroidal MRAs. ACE, which is American Association of Clinical Endocrinology, they have also recommended, and this is a fine print, I'm going to blow it up a little so that you can read it, and a non-steroidal MRA with proven CKD and CVD benefit, which is actually Finerenone. At the moment, we have only Finerenone. I believe there are some more in the pipeline, but at the moment, we only have Finerenone. Is recommended for persons with type 2 diabetes with GFR of more than 25 with normal serum potassium, because this drug has the potential of causing hyperkalemia, though much less than conventional MRAs. But this does have some potential of causing hyperkalemia, so you have to make sure that there is no hyperkalemia. 5 is the limit. It has to be below 5 before you can start this drug. And albuminuria, if present, that should be benefit, and patients should get more benefits. And these patients should be on maximum tolerated dose of RAS blocker. I think every society has the same recommendation. All of them, they have recommended Finerenone in type 2 diabetes with kidney disease, provided their GFR is more than 25 and provided they are already on RAS blocker and SGLT2 blockers. So if you are convinced that Finerenone is a useful, novel and game-changing therapy, you could use it in your patient, and this is the dosage. If somebody has GFR of more than 60, which is considered clinically normal, and I think the dose is 20 milligram once daily. Even in this group, you could start with 10 milligram, but I think the optimum dose would be 20 milligram. But those patients who have GFR of 25 to 60, which means reduced GFR but not critically low, their dose is 10 milligram. There is no further titration actually, either 10 milligram or 20 milligram. But if GFR is less than 25, then this drug is not recommended. And other MRAs are also contraindicated, but this one is not recommended also. So measure GFR and K prior to initiation and monitor 1 week after starting, and then as necessary. It would depend on the kidney functions and cardiac condition, because potassium is particularly risky. Hyperkalemia is very, very dangerous for people with background heart disease and potential arrhythmias. So I think if that is the case, you should be very, very careful. And of course, as I said, if potassium is more than 5 or GFR is less than 25, then the drug is contraindicated. So that was all. I hope I was able to give you a good overview of the research data, 3 major studies, and the recommendation by various authorities, and you can use confidently in the approved indication. And the approved indication is type 2 diabetes with CKD 2 to 4, stage 2 to 4, and with with those patients who are on fully tolerated RAS blocker and SGLT2 inhibitors. Thank you very much. I hope you watch my next videos also, and if you want to join my channel, you can scan this one, or you could just type this word Medurstand anywhere on the internet. You will be right in my channel. Thank you.